I'm super excited to be joined by Huw Davies today. Huw Davies is a national expert in ultrasound-guided foam sclerotherapy and one of the main advocates for foam sclerotherapy in the United Kingdom. Huw trained with Professor Andrew Bradbury, who was one of the major innovators in ultrasound-guided foam sclerotherapy here in the United Kingdom, and who helped develop what is now regarded as the English method of foam sclerotherapy. Let's hear what Huw has to say about the crisis of access to vein treatment in the NHS, the crisis of leg ulceration, the NICE guidelines, and some of the problems with landmark studies such as the CLASS trial and the EVRA trial. And be sure to stay to the end where we talk about possible solutions to the leg ulcer crisis in the UK. Be sure to check out all the links in the description box below. Well, there's no doubt, Huw, that you have a long-term interest in ultrasound-guided foam sclerotherapy and how it's applied to the treatment of superficial venous reflux, varicose veins, leg ulcers, and so on. And you worked very closely with Professor Andrew Bradbury and his team, Gareth Bate and others. And what's happened now since I invited you to this podcast is I've noticed that you are one of the authors or investigators on a whole bunch of very important papers.
I don't know.
So how long have you been interested in foam sclerotherapy, Huw?
I guess it really started when I started my research with Andrew many years ago now, 10, 12 years, maybe longer, 15 years ago. As a kind of junior registrar, I didn't have a great deal of awareness. I knew we'd moved away from stripping and high ties, which I was doing as an SHO, but it wasn't really until I came to work for Andrew, started doing some endothermal, and then him and Gareth introduced me to foam sclerotherapy. I was like, this is very different from what I was doing as an SHO and a general anaesthetic, where patients were black and blue afterwards and a bit sore, compared to a walk in, walk out, very quick and a very effective treatment. And it's something I think it's a little bit more difficult to master than some of the other vein treatments. It looks very easy, put a few cannulas in or cannulate the veins with however you choose to do it under ultrasound and instill some foam. But it's a lot more nuanced than that, as I'm sure you agree, Haroun.
Yes. The technique that Andrew Bradbury perfected and published very early in 2010, perhaps even earlier than that, 2010, 2012. That is sometimes called the English method. Is that a term you're familiar with?
Yes. I remember going to present on his behalf many years ago at controversies on the English method. It was fantastic. Yeah. So that's very much the method I'm familiar with and that I use for my treatments.
Has it changed very much from Professor Andrew Bradbury's original description?
I don't think it's greatly changed. I think, we all learn our own different ways and means of doing things, and things that work for us, we pick up from our trainers and indeed trainees as we move onwards with our career. But I think the overall method of treatment is still very similar to how he described that 15 plus years ago now. I certainly treat most of my veins in that way.
Okay. And you're in NHS practice, aren't you?
That's right, yeah.
So am I right in saying that most of the patients who have treatment in your unit in the NHS have ultrasound-guided foam sclerotherapy?
I think it depends a bit on who's offering the treatment. There are some of us that are big foam enthusiasts in the department, and others that are more endothermally based or have less of an interest in venous disease. And they tend to stick to the endothermal truncal ablations, maybe doing tributaries in some cases with foam. But I think we've certainly found in our NHS practices since COVID, it's very hard to get operating room space. So actually finding the space to be able to do phlebectomies, etc., rather than performing the venous treatments in a treatment room is increasingly difficult. And so more and more of my colleagues are coming to me and asking about foam for tributaries and indeed foam for truncal ablation.
Right. But what is your practice, Huw? Is your practice foam sclerotherapy for truncal reflux?
It depends a bit. If it's a very small trunk or a tortuous trunk neovascularized, then foam would be my primary choice. If there's a nice straight bit of truncal ablation to perform that, then I would do that with radiofrequency, because that's what we use in our health board. And then very much foam sclerotherapy to treat all the tributaries around that. So I try to do it all in one sitting.
Okay. Well, that's a discussion I know that we're going to develop at the British Association of Sclerotherapy meeting.
Yeah.
You're going to discuss how you do foam sclerotherapy. You'll tell us the nuances of the English method as adapted by you.
Sure.
But today, we're going to talk about how foam sclerotherapy is applied in NHS practice. And at this juncture, I'm going to play your presentation that you very kindly prepared in advance. And then we're going to use that as the basis of our discussion. So let's watch your video presentation.
Haroun, thank you for inviting me to talk on ultrasound-guided foam sclerotherapy and varicose vein treatment in the NHS. I'm Huw Davies, a consultant vascular surgeon in the South East Wales Vascular Surgical Network, and my NHS practice is based in the University Hospital of Wales. I did my research doctorate looking at the impact of NICE Clinical Guideline 168 on the management of superficial venous disease. NICE CG 168 gives us great advice on the treatment of varicose veins, suggesting a hierarchy of treatment, starting with endothermal ablation. If this isn't suitable, then it suggests we offer ultrasound-guided foam sclerotherapy and surgery if neither endovenous treatments were suitable for the third line. It also suggested that we should consider treating tributaries at the same time as performing truncal ablation. But is this hierarchy valid? Well, I performed a review of RCTs comparing outcomes of foam sclerotherapy and endothermal ablation. From an anatomical perspective, endothermal ablation resulted in a higher occlusion rate than foam. However, there are a couple of caveats here. Patients themselves are less concerned whether their GSV is occluded on ultrasound, and they're more concerned as to whether they have a recurrence of their veins or symptoms. Indeed, there was no significant differences in patient-reported outcomes between foam sclerotherapy and endothermal ablation. Also, Haroun, as a fellow foam enthusiast, you know that endothermal ablation is relatively straightforward to perform. The vein is punctured under ultrasound guidance, a sheath inserted. The catheter is then advanced a predetermined distance from the junction. The ablation device, be it laser or radiofrequency ablation, is then activated, and you withdraw this at a predetermined rate. This delivers a predictable ablation result. If you drill down into the methods of these RCTs, for example, the CLASS study, which is a brilliant pragmatic study and well designed, there are some differences as to how foam treatments are delivered between enthusiasts and the methods described. In the CLASS study, they described placing a cannula around the knee and I think 10 or 12 mil of STS foam injected. They then recorded anatomically the outcome as to whether the full length of the GSV was occluded. Unsurprisingly, this was disappointingly low compared to endothermal ablation, where the whole great toughness vein was treated. So personally, I think if you understand the mechanism of action of STS and its properties, that you'll realise in the CLASS study they only actually properly or perhaps over-treated the GSV from the cannula at the mid-knee, the knee to the mid-thigh. And indeed, achieving any full-length GSV closure is perhaps a pretty excellent result. All these facts led me to conclude that perhaps strict adherence to NICE's treatment hierarchy wasn't entirely justified. Katie Darville, Gareth Bate and Andrew Bradbury reported their mid to long-term results after truncal foam sclerotherapy, a unit in Birmingham with real experience at delivering this treatment. They reported a fantastic patient satisfaction as well as excellent and durable results as reported by PROMS out to at least 5 years, and that only 15% of patients required retreatment. Manj Gohil looked at the costs to the NHS of various treatments back in 2010, so I expect inflation has significantly increased these costs since then. He reported foam sclerotherapy as £430 per patient, both laser and radiofrequency costing around £2,000 and surgery £1,200. All of these treatments were delivered on an outpatient basis. Treatment costs, NICE CG 168 were calculated on, found surgery was the most expensive, endothermal ablation around a third cheaper, and foam to be half the price of endothermal ablation, and about a third of the cost of surgery at around £300. Interestingly, this was only slightly more than conservative management with compression hosiery at £234 per patient. NICE also calculated the additional costs in the case of need retreatment, as £417, which was more than a treatment with foam sclerotherapy. They specified this was due to the need for an additional consultation and outpatient appointment and ultrasound scan. But ultrasound-guided foam sclerotherapy was judged as being less cost-effective than endothermal ablation. This was mainly due to the high recurrence rates anatomically published in RCTs that I reviewed. In fact, NICE CG168 assumed that 20% of patients would need a further top-up treatment within 2 months of their initial treatment. I mean, that's certainly not data from foam enthusiasts and doesn't demonstrate anything like high need for early top-up treatments, though I accept that NICE places quite a low significance to single-centre case series data. To me, it seems like a no-brainer to deliver a cheap and cost-effective treatment over the cost of compression hosiery for conservative management, particularly when we know how poor patient compliance is with this. And we all know that NHS is struggling with its finances at present. The NHS Confederation published its report into the state of the NHS finances before 25. My 3 key takeaways from this are: 1, the biggest challenge facing us as staff in the NHS, as well as our NHS leaders, is the ability to balance the books whilst protecting our patients' safety, especially as many organisations are having to achieve significant efficiency savings. A large comprehensive survey of NHS leaders by the NHS Confederation demonstrated that many organisations are having to meet high efficiency targets of 5% or more. Indeed, some organisations are requiring 11% savings. This is the tightest financial position the NHS organisations have faced in a very long time. Thirdly, 60% of NHS leaders think they're going to need top-up funding from the government within a year to have any chance of delivering their efficiency savings. So as phlebologists, we have many challenges ahead of us. We know that varicose vein interventions significantly improve quality of life for our patients, and that endovenous interventions are well proven to offer value for money, well under the NHS willingness to pay threshold of £20,000 per QALY. We have excellent evidence that our varicose vein treatments work well, but treatments on the NHS need to be cost-effective as possible to allow us to treat and improve the quality of life of as many of our patients as possible, especially for a condition that's as prevalent as superficial venous disease. Speed and efficiency of treatments is also important, particularly given the many venous interventions were stopped entirely for many months or years during the pandemic. Waiting lists are ever growing and becoming more and more insurmountable. There's certainly a real postcode lottery developing across the UK with rationing of treatments. Dan Paradise and his group performed an excellent piece of work looking at varicose vein treatment provision in the NHS. They found many local commissioning policies were not compliant with NICE CG168 recommendations of offering all those with symptomatic C2 varicose veins or worse treatment. Indeed, half of the patients who should have been offered treatments weren't receiving them. Despite the introduction of evidence-based intervention program to promote the adherence to NICE CG168, between 2017 on the left map and 2019 on the right, there were an increasing number of areas not adhering to NICE CG168 treatment thresholds. The only ones adhering were in green. Those in amber, the increasing number in amber, required specific circumstances to allow varicose vein treatments. These were usually evidence of skin damage used to ration these treatments. Some areas marked in red went even further, specifying that venous treatments could only be performed for ulceration and bleeding alone. And this rationing of treatment is increasing and restricting patients to well-evidenced, and clinically effective treatment. Indeed, our waiting lists across the UK are increasing. And how are we to apply these restrictions to people already promised intervention? When we get to leg ulcers, things are even worse. They are disappointingly common. 0.3%, around 2 million people in the UK, are living with a leg ulcer at present. NICE CG168 made very aggressive recommendations to refer all patients with a skin break below the knee for more than 2 weeks for a vascular review. This was supported by the Royal Society of Medicine Venous Forum guidelines. However, the now outdated SIGN and RCN guidelines didn't consider referral until the ulcer had been present for more than 12 weeks in the community without signs of healing. I've looked at the impact of NICE CG168 on leg ulcer referral practices. Locally in Birmingham, where I undertook my research, we already had great relations with primary care and nursing teams in the community. With the advent of NICE CG168, we actively went and advertised the importance of referring patients early and had an open door policy allowing anyone to refer us leg ulcers to see urgently, to assess for any underlying vascular cause and to perform intervention of the underlying pathology. We doubled our referral numbers, in fact, post CG168. Sadly, nationally, the picture was not the same. I use a thin database, which has had around 2 million active patients whose primary care records were scrutinised. In each 18-month period before and after the guideline introduction, around 7,500 new diagnoses of leg ulcers were made. Sadly, only around 250 of those patients, or about a third, were actually referred on for review, both before and after the guideline introduction, with no statistical improvement at all. Endovenous intervention for ulceration is well evidenced by the EVRA study. Early intervention improves healing, reduces recurrence, and is cost-effective. We also know that the longer a leg ulcer is present, the harder they are to heal. Indeed, one of the criticisms of EVRA was that ulcers had to be present for less than 6 months. This emphasises the importance of a really early referral to vascular specialists and good relations with our community practitioners. We as phlebologists need to advertise our services to the community. I personally invite community nurses, with the permission of their patients, to attend their patients' venous intervention so they can see firsthand how easy a modern endovenous intervention can be performed. They're so surprised at how quick and simple it is, particularly with foam sclerotherapy. They're delighted to offer this intervention to their elderly patients suffering from ulceration in the community. We all know the cost of leg ulceration to the NHS is massive, nearly £2 billion a year and around £7,600 per patient per year, and that was back in 2016. As our waiting lists grow and our population ages, more and more patients are going to be developing skin complications and progressing to ulceration. As a note, managing obesity costs £5 billion a year, so we're nearly half the cost of the problems caused by obesity. The EVRA investigators were really keen phlebologists, and that was evidenced by their use of foam in 50% of the treatments. Surgeons performing the interventions really realised the flexibility, cost-effectiveness and ease of this treatment. I wonder if it possibly contributed to the early treatment of venous insufficiency being so highly cost-effective. So how do we address all of these problems? Well, certainly there's no more money. Rationing is already prevalent and increasing, and this casts concern for those patients who are already on waiting lists. Will they be re-reviewed? Will they have their treatments cancelled based on old letters? Or be lucky enough to have their interventions, albeit with a long wait, whilst their neighbours have to suffer reduced quality of life in the name of cost savings and live with their symptomatic varicose veins? I wonder if increased understanding of foam sclerotherapy and thus improving outcomes may offer a cheaper office-based solution with a high throughput of patients to help with this. There's also debate about the increasing role of paramedical specialists performing treatments. This is very hotly debated, and I think we're a long way from establishing a way forward here, and certainly I'm not going to drag me into an answer today. So to conclude, in my opinion, ultrasound-guided foam sclerotherapy is safe, cheap and effective. But as those who are enthusiasts know, you need to be more meticulous in your planning and technique than you do with endothermal ablation. Doing this, educating our colleagues in the art and the flexibilities of foam sclerotherapy might maybe make some inroads into the varicose vein crisis in the NHS and the UK population. Finally, as vascular surgeons and phlebologists, we need to support and publicise National Wound Care Strategy Programme, NICE CG168, and integrate ourselves more closely with our community colleagues, providing education support and an open door policy. Thank you so much for inviting me to talk, Haroun.
I've watched it 2 or 3 times, and it's really very good. Very good.
Thank you. I think it was based, back at the start of my research, I looked a little bit into, sorry to sort of jump in.
No,
I looked into,
jump in.
I looked into, I was learning how to do foam sclerotherapy. This is jolly quick, jolly easy. It's really applicable and a really low cost way of doing things. And so I really wanted to have a bit of a look at the evidence of foam versus endothermal ablation, the level 1 RCT evidence. And that's what I mentioned a bit in my presentation. I don't know if you want to expand a bit on the fact that actually, in terms of the patient-recorded outcomes, they're very, very similar. The patients will describe a similar improvement in their quality of life, etc., of both endothermal and foam. It's the anatomical outcomes that foam seems to lag behind endothermal ablation. And I think there's two little parts of that. There's partly the fact that patients don't really care if their GSV is open or not. They care whether they have venous symptoms, whether they can see varicose veins, etc. I guess part of part of the anatomical outcome is related to that. If you have an open GSV, which is refluxing, you're going to have symptoms. But actually, the other part that is interesting is when you drill down into the methodology of those papers. I think Rasmussen and Klaas particularly describe their foam sclerotherapy treatment. It would be probably quite different to the English method or the methods that you and I would use, Haroun. And most of those describe a single cannula placed at around the level of the knee and instilling 10 mils of 3% STS foam into the trunk. I think it was STS in both those papers, but sclerosant of appropriate strength for trunk anyway. And then looking at the whole GSV for occlusion, and I think what surprises me is we managed to get 30+% occlusion of the whole GSV when you've only treated the bit around the knee. So I almost think that's positive for the foam sclerotherapy side of things, personally.
I think that point is well made, and I think that is surprising when you look at the way that it was done, particularly in the CLASS trial. The CLASS trial, you were very generous in describing it as a well-designed study.
Well, it was very pragmatic, I think.
I don't think I would use the term personally of a well-designed study, because the title of that paper, you weren't involved in it, by the way, were you?
No.
Okay. Well, the title of that paper suggests that they're comparing laser with foam and with surgery. But in fact, what they did, without actually drawing too much attention to it, is they treated nearly a third of the patients with laser. They treated them with foam as well, to the tributaries.
Yeah.
And so I think perhaps a more accurate description would be laser plus or minus foam versus surgery. Not all the centres did foam sclerotherapy, and there was a huge amount of dropout. It was a huge study that they looked at over 6,000 people, I think, and they only randomised nearly 700. So I think you were generous in your description of it being a well-designed study. The method of ultrasound-guided foam sclerotherapy by today's standards would be regarded as inadequate. So why is everybody still quoting the CLASS study? I note that at the last Venous Forum meeting, Professor Brittenden was asked to give a presentation on the CLASS study, and to my surprise, none of those objections to the CLASS study were made. Now, I don't want to get you into an argument with an esteemed colleague, but that does surprise me. Did it surprise you? Were you at the Venous Forum?
I was at most of the Venous Forum last year. I missed her talk, unfortunately, on the CLASS trial. I think, I do agree with you. There's a degree of people wanting to be involved in a major RCT, and it's a very important question to answer when the CLASS study was first commissioned. But as you say, I don't think it gives the whole result, and it does require the reader to really critically appraise the methodology in that to make sure they can draw their own conclusions from that. I think looking at with some degree of bias Andrew Bradbury's work and the work that he's been involved with, and other units publishing data on foam, they're admittedly their case series data, but they've got fantastic results.
Yes.
And that goes out to medium and long term, and great patient satisfaction as well. So I think it's like every piece of research, you have to be pragmatic in your design of it. But at the same time, the reader needs to understand that actually you can't capture the perfect treatment and the perfect follow-up for every patient. And I think the technology moves on, the treatments move on, don't they?
Yes, they do. And I think that the NICE guidelines, as they currently are a hindrance to vein treatment, because you alluded to the fact that the hierarchy is perhaps not justified. But I recall that some people on the NICE board would have wanted foam and endothermal to be joint first, not the hierarchy to be endothermal, the preferred one.
That's certainly what I heard as well.
So do you think it would be appropriate for us to say the NICE guidelines now are not actually appropriate in 2025, having been published in 2012? And it seems to me that the CLASS study was a major influence on those NICE guidelines. Shouldn't we say to NICE, hang on, particularly you, Huw, in a position that you are in, you should say to NICE, look, hang on. The insistence that we consider endothermal first, and then only if that is not possible, we should then go on to ultrasound-guided foam sclerotherapy. Shouldn't it be joint first? do either?
I think that's probably certainly a case for that, Haroun. I think the difficulty is that not all people that treat veins in the NHS are phlebologists or have an interest in venous disease. You can still get very good results with endothermal ablation, and I think my general feeling with endothermal, just truncal ablation, it does improve. It's well proven to improve people's quality of life, and it's a well-lasting, a durable treatment. And it's moderately idiot-proof if you don't have a great degree of interest in venous disease. Whereas I think foam sclerotherapy has an unfair reputation for poor results, and that is partly through poor understanding of the pharmacokinetics of the chemical involved and how it works. It's partly through lack of understanding of how to perform the treatments. And also there's a little bit of, I think, probably lack of consenting. Well, consenting is probably the wrong word. Lack of patient understanding of the treatment process. So there is no treatment that gets rid of your veins. Click, gone. There is no such thing as a treatment. Whatever you do, even if you strip the veins out, you phlebectomize, etc., then they've got wounds to heal, you've got bruising to settle, etc., etc. There's no way of just magically disappearing your veins. And I think it's quite important when you consent your patients and you inform them of the treatment. The actual procedure itself is just the start of the treatment. The wearing of compression afterwards, the regular mobility to reduce your risk of thromboembolism. And then keeping an eye on the kind of lumpy, bumpy areas, getting in contact if you've got any tender areas that need aspirating, etc. That's all part of the treatment journey, and it does take some time to get the cosmetic improvement, not necessarily the symptomatic improvement, but certainly the cosmetic improvement takes some time.
I think that's fair to say. The problem, of course, is that not all veins are suitable for endothermal ablation, and just turning our attention to the EVRA trial, which is, again, another landmark study that's often quoted, you make the point quite rightly that foam sclerotherapy was the dominant modality of treatment in that study. You've made the point and you've emphasized it, but I don't think a lot of specialists who quote the EVRA trial realize what percentage of people were treated by ultrasound-guided foam sclerotherapy. And it may not just be a question of randomization. It may be that actually a lot of the patients were not suitable for endothermal. You need a fairly straight vein. A lot of veins are not amenable to a catheter-based treatment.
I think, correct me if I'm wrong, but I think it was I don't think there was that the EVRA protocol suggested you had to stick rigidly with the NICE recommendations. I think it was any form of endovenous treatment performed within 2 weeks of seeing the patient, I think.
Yeah, no, that's true.
And I think what it shows is that people that were investigators and randomizing patients on the EVRA trial were venous enthusiasts, phlebologists, people with a specialist interest in venous disease, and there's some very large names on that paper. And actually it shows that those that are interested in treating venous disease understand foam sclerotherapy and understand its versatility, and that they get very good results from it. And actually EVRA shows that because it has an excellent improvement in ulcer healing rates and ulcer-free time, and is very cost-effective. So it shows that those who are interested in foam understand that it's brilliant and are using it. So I think that's part of the kind of reason that half the patients had foam alone.
My take is that perhaps foam sclerotherapy is much more applicable to people rather than endothermal, and that's why it was the dominant. I suspect, I'm not saying there was a bias towards foam or to endothermal, but I suspect in the absence of any bias, the fact that so many people were treated by foam suggests to me that there might have been some anatomical reasons why it wasn't possible.
I mean, it's certainly very versatile. And I mean, in my NHS practice, I have really been reaching out to the community team and the wound teams in the communities to try and encourage them to refer leg ulcers into the NHS for treatment of their venous disease. And actually, I've gone out and I've spoken to the sort of tissue liability leads in the community, and I've explained endovenous treatments to them with their patients' consent. I've asked them to come along to one of their patients' treatments, and they've all been shocked, I think is the word, of seeing how simple, straightforward, quick and easy a foam sclerotherapy ablation could be. And actually, a lot of these frail elderly people, they thought, well, the surgeon will never take those patients to theatre and give them a general anaesthetic and strip their veins out. Actually, we don't need to do that anymore. We can bring them in half an hour, treat the veins, and they're walking up and about again and on their way home. And it's completely revolutionised venous intervention.
That is true, yes. Now tell me then, why is it that the number of people with an active leg ulcer is increasing in the United Kingdom?
Well, multifactorial, aging population, more comorbid population. We've got much greater difficulty in access of healthcare, I think, particularly post-COVID. There's always seems to be a reluctance, this is probably the wrong word, there seems to be difficulty in getting these patients in to see a vascular surgeon. They seem to be managed in the community by district nursing teams, community nursing teams with dressings, usually compression dressings, fortunately, but with no one understanding that the leg ulcer is actually, it's not the underlying pathology. The underlying pathology is the venous reflux, usually, by and large. And actually, the leg ulcer is a symptom of that, or a sign of that. And actually, you can treat the leg ulcer with your compression dressing, and by and large, it will heal at given time, but it's going to come back again if you don't treat the underlying reason. I think it's really important that we get people into the NHS and get their venous disease treated if appropriate.
One of the suggestions that have been made in a BMJ editorial by Dan Carradine and Bruce Campbell is that we should centralize services more, and we should have more specialization in phlebology. Yeah. Have you read that paper, Huw?
I read it. It was some time ago. It says the venous leg. Yeah.
There's no doubt there is a crisis, and there's no need for we're drawing the attention of other healthcare professionals to the fact that there's a crisis.
And when they all land on our doors, there'll be even more of a crisis.
Yes. So, but I didn't find that the solutions suggested in that BMJ editorial could be applied. You made the point that the NHS is strapped for money. I can't see any particular developments happening to increase access to the current guidelines. I mean, we've got the NICE guidelines, we've got the guidelines from the Royal Society of Medicine, we've got the Venous Forum guidelines, we've got the current president of the Venous Forum telling us about the crisis and suggesting that we should be centralizing services and perhaps have tertiary referral centers for venous stenting and deep venous reconstruction. Surely ultrasound-guided foam sclerotherapy is the answer.
I think you're probably right in the treatment of leg ulcers. It's such a quick and easy treatment to perform that can be performed so cheaply and easily. And I agree, the throughput of patients could be much higher. You could be performing this in a treatment room, which is significantly cheaper than running with a theatre team, trying to do more and more of this in the NHS. And you can also go out and I agree with Bruce and Dan with regards to centralisation of deep venous services. I think that's quite a specialist topic. And, I offer some of that service myself. But in terms of your treatment of your venous disease, your superficial venous disease, I think the drive is to perform those treatments closer and closer to people's homes. There's a balance to be struck. You can't have specialists trotting off for an hour and a half each way to perform 4 or 5 interventions when they'd be better spent paying for their time to be treating more patients. But at the same time, it's very difficult to ask a patient who's elderly with a leg ulcer, often from a socioeconomically deprived area, to traipse for an hour. And certainly in my health board, it could take 2.5, 3 hours to get to the hub from some of the furthest boundaries. It's very difficult for people who don't have access to a car for that purpose. So, you can pack all the kit you need for foam in a briefcase, can't you? And the same one goes for your scanner, and away you go to anywhere that's got a couch that you can raise the end of. So,
I don't know if you saw my chat to Ron Bush about the subplexus injection of foam.
I started watching it on Friday, actually, when I was on call, but I got distracted very quickly, unfortunately. The subulcer plexus, I think, is a really interesting thing to look at.
Yes. Well, I hadn't realised. Well, I hadn't realised that Ron Bush had described this technique 15 years ago, and he called it terminal interruption of reflux source, TERS.
I think
And he made the statement that he can treat successfully 98% of ulcers by injecting the subplexus area with foam. And in some cases, he doesn't even need an ultrasound scan. Now, I have no doubt that not all ulcers are amenable to this, but it certainly made me think very carefully about the application of foam.
he has does have some fantastic results. The applicability to the NHS and the NHS leg ulcer, I guess, is difficult. Many of our patients have had ulcers for a very, very long time.
Yeah.
And, we certainly know there's good evidence the longer you have an ulcer present, the more difficult they are to heal.
Yeah.
But I certainly think...
I know you don't want to be drawn on this, Huw, but I'm going to ask you anyway, and you can tell me how uncomfortable you feel about this. I'm surprised now that some of the eminent authors of many of these trials are not backing foam sclerotherapy quite as much as perhaps they could be, particularly in the treatment of leg ulcers. For example, I don't want you to comment on this. I did an interview with Bruce Campbell, who's now the president of the Venous Forum. He was telling me that his preferred method of treating superficial venous reflux is glue, which I have to say I was surprised about, and I did express that surprise with Bruce. And I'm also surprised that some of the leading authors of other papers are now involved in research, randomized controlled trials of glue versus endothermal versus endothermal, different frequencies, different modalities. Surely, with the crisis that we have just in leg ulceration, we need more enthusiasm amongst these prestigious organizations for foam. And I know you don't want to be drawn on the fact that we don't want to be drawn on the fact that there are people who could do this, who could require very short periods of training in the community. Ultrasound-guided foam sclerotherapy, with appropriate training from people like you, Huw, could be rolled out on a community basis. And this idea that we need more tertiary referral centers in hospitals would not be needed. We could heal a lot of the ulcers that are currently active if we were to take foam sclerotherapy out into the community with perhaps non-consultant or non-vascular surgeons. Why is it that we need to refer leg ulcers to vascular surgeons, Huw? Why not community-based ultrasound-guided foam sclerotherapy by non-vascular doctors?
I think my understanding is around 70% of leg ulcers are venous in origin. So that leaves still quite a large number of leg ulcers that are not venous in origin. And those that are not venous in origin tend to have slightly more difficult to treat, risky to ignore / miss etiology, so mixed arteriovenous, for example. People who've got margins ulcers, things that you really need to make sure you're not missing. And there's a limit to how much I think tick boxing, checklists, clerking pro formas can safety net that. I certainly think it's important for someone to see an expert in leg ulceration who's able to identify, those patients that have simple venous disease and then filter out those who require some more invasive intervention to treat that. So who that needs to be, well, does it have to be a surgeon? It probably doesn't have to be a surgeon. A very experienced nurse specialist, nurse consultant could probably be doing that. I don't know how much more cheaply that would be, how much cheaper that would be for the NHS, probably a little cheaper. And then with regards to foam sclerotherapy as a treatment modality, I mean, you and I are both massive foam enthusiasts, Haroun. I think it's important that we continue to extol how useful it is, how versatile it is, but it's also partly beholden on us to train people in the use of foam sclerotherapy. You and I are both doing a training day in a few weeks' time near Bristol, I think, for that, which I'm greatly looking forward to. And I think who comes on that, again, it's doesn't have to be a doctor performing the procedure necessarily, or a consultant performing the procedure necessarily. It needs to be someone that's able to prescribe, to give a medication. It needs to be someone that's able to deal with complications for foam sclerotherapy. And I don't just mean lumpy areas, skin staining. I mean anaphylaxis. I mean neurological adverse events, etc., which will be extremely rare. But you do need to have a bit of training to do that. And again, that I guess goes a bit back to the discussion earlier of taking foam sclerotherapy out to the community. Yes, you can do that, but you do need to have a bit of backup in case something happens. I've worked in a unit where there was a case of anaphylaxis whilst the patient was having foam sclerotherapy. Fortunately, there was an EpiPen in the room, which was administered. The patient went to ITU for observation for 24 hours and discharged the following morning. But it was proper anaphylaxis. People were ready for intubation and all sorts. You've got to be able to realise that there are some complications that are a bit extremely rare that you need to have some good training to deal with. So I think you have to be confident and capable in dealing with those, whoever performs the treatment. You have to be able to understand the risks, consent your patients appropriately. And you have to be able to take make the decisions around that. So I don't think someone performing foam sclerotherapy in the community, not under the supervision of the consultant, they need to be able to take responsibility for that. If there's a problem, it can't be the consultant remotely taking responsibility. I have no strong feelings on who performs it as long as it's someone with a venous enthusiasm and who's an enthusiast for foam sclerotherapy. If they're true believers in all of the above, then they'll do a fantastic job, no matter what their job title is.
Well, that's great. Well, look, Huw, you've been very generous with your time. You've produced a really interesting presentation for us, and I look forward to meeting you at the BAS and meeting you in person.
Yeah.
And I look forward to seeing you in March, where we're going to be meeting up in Bristol and doing a foam sclerotherapy workshop.
Yes, looking forward to that as well. Lots of education.
Okay, look, thank you very much, Huw. It's been a pleasure.
Pleasure.